بسم الله الرحمن الرحيم. السادة الحضور، الزملاء الكرام، أساتذة واستشارية جراحة الأوعية الدموية بجمهورية مصر العربية، أنا يعني يشرفني أن أكون معكم وأرحب بسيادتكم جميعا، وإن شاء الله يكون سيمبوزيوم في إيه؟ طيب صوت كويس؟ يكون سيمبوزيوم مفيد نقدر نراجع فيه معلوماتنا ونشوف الجديد في موضوعين، مش موضوع واحد النهارده. نوع عن البريفرال ارتيريال ديزيز ده وان سيمبوزيوم، والاذر وان كرونيك فينس انسفيشنسي. انا بس هيكون دوري والدكتور طارق عبد العظيم زميلي وصديقي العزيز هيقدم البروجرام بعد كده. أنا بحب بس أشكر شركة مينا فارم على تنظيمها الجيد والرائع دائما لهذه اللقاءات العلمية. دائما بتكون في المقدمة وفيري فروتفول، والحقيقة بنطلع فيها ببعض الفوائد والنتائج الكويسة. ويخص الذكر بقى طبعا الدكتور أنور مدير عام شركة مينا فارم. هنقول الأسماء كأني كده بقدم منتخب بيلعب ماتش كورة، لأن العدد كبير لأنهم مقسومين لمجموعتين، في مجموعة خاصة بالبراكسيلان ومجموعة خاصة بالدوكسيوم. فعندنا المينا فارم سيلز مانجر بنذكر دكتور باسم قيصر والدكتور توني سامي والدكتور نبيل والدكتور تامر والدكتور أمير. والماركتينج طبعا غني عن التعريف الدكتورة مريان عياس، من يعني سنوات طويلة جدا وهي بترتب للإيفنت ده دايما، ومعاها الدكتورة إيريني والدكتور كرولوس. يوجد كمان معانا الديستريكت مانجرز اوف ذيس برودكتس، دكتور ماجد فهمي، الدكتور ماجد ملاك والدكتور جورج. الحقيقة أنا برحب بيهم أو هم بيرحبوا بينا برضو، وبنشكرهم جدا على هذا التنظيم الجيد، وإن شاء الله كلنا نستفيد بالاجتماع والندوة العلمية الصغيرة دي اللي هي مش هتاخد ساعة، ساعة ونص إن شاء الله. اتفضل دكتور طارق بيه.
شكرا دكتور عمرو، وانا برضو طبعا بشكر شركة مينا فارما على التنظيم واللقاء العلمي، وان احنا نجتمع بالمجموعة الجميلة دي من جراحين الأوعية من يعني مناطق مختلفة من مصر، وإن شاء الله يبقى لقاء علمي مثمر زي ما الدكتور عمرو قال. فهنبدأ إن شاء الله بأول محاضرة. It gives me great pleasure to introduce my dear friend Dr. Fuad Saadeddin, Professor of Vascular Surgery at Cairo University, and he will be discussing the updates on intermittent claudication in peripheral arterial disease. دكتور فؤاد.
Thank you very much. طبعا أنا مش هقدر أعيد نفس الكلام، بس الكلام اللي أساتذتي الدكتور عمرو جاد والدكتور طارق عبد العظيم قالوه طبعا أنا بعيده يعني. وبشكر برضو شركة مينا فارما على إتاحة هذه الفرصة للتواجد مع هذه المجموعة الرائعة يعني من جراحين الأوعية الدموية يعني. Obviously I will not be talking about intermittent claudication كله يعني. I'm just gonna focus on a few points regarding their latest update which was published last August يعني. But before I do that, as a refresher كده, I will go through a few cases with the escalating levels of complexity, I guess, just to freshen up in a Friday morning. The floor is open to discussion, and obviously anyone who wants to say anything can go ahead and ask, or talk, or comment. So the first case is about a 76-year-old man who obviously has a low ABPI. He has an SFA occlusion, and he has intermittent claudication after 500 to 700 meters, and there is no lifestyle limitations. So my question to the floor is, what do you think is the optimal management for this man? Dr. Omar Bey.
Conservative management.
Thank you, sir. Would anyone else like to comment on Dr. Omar's opinion? Dr. Nasser?
I agree with Dr. Farouk. Best medical treatment is the first line. And at the same time, if it is interfere with the lifestyle limitation, is still the best medical treatment, supervised exercise. Don't rush for angioplasty. Okay?
Thank you, sir. I would say that this is the yes. I'm sorry, Dr. Ashraf. Yes, I'm sorry.
هو الحاجة المهمة بس ده دايابيتك ولا مش دايابيتك؟
Okay.
تفرق لأن لو مش دايابيتك ومفيش سموكينج العملية سهلة، بس لو فيها دايابيتس هنضيف على الكلام ده بقى المانجمنت اوف اثيروسكلروزز والمانجمنت اوف دايابيتس بالإضافة للكونسرفاتيف.
Yes. Okay, so conservative treatment, I guess, does include two parallel lines. One of them is the risk factor modification that Dr. Ashraf has alluded to. The other is claudication-specific treatments. Okay, Dr. Amr.
أضيف نقطة صغيرة قوي إن حضرتك يا دكتور فهد قلت إن سموكر. And one of the crucial things is to convince him to stop smoking. This one of the important lifestyle modification يعني management.
Or at least try to convince him. Yes.
It's hardly yes, but it will differ completely if he stops smoking in his course in the conservative medical treatment.
And that is why smoking quitting programs should be available to offer help for those patients. Yes, sir. Dr. Mahsoub. Yeah, of course. Yes. Dr. Mahsoub, اتفضل.
واحنا حضرتك كل البورد متفق على الكونزرفتيف تريتمنت. لكن في هاو لونج والاوبزرفيشن بتاع العين ده، هل الكولوديكيشن ديستانس بتقل ولا تتحسن ولا زي ما هي برضه؟ يعني اقدر اقول ان العين ده يعني الكونزرفتيف بتاعه مينيمم 3 مانثs واشوف العين بتاعي بيتحسن ولا لا. لو ما بيتحسنش يبقى ما زال قائم الانجيوبلاستي موجود.
Yes, so Dr. Mahsoub is pointing to the fact that once a patient is diagnosed with peripheral artery disease, he should be followed up regularly to see how he is doing, whether by us or by other specialties. Yes, sure.
هو طبعا excellent opinion, Professor Mahsoub. لكن if you have an asymptomatic patient that does not affect his lifestyle, he never get better. And this is very important.
Yes.
If you are in United Kingdom, you're claudicant, you stay claudicant for 5 years. If it doesn't affect your social life, no one will touch you.
That is true. And this will appear in the upcoming cases. So the second case is a 72-year-old man who's being referred for peripheral artery disease. That's the referral question, I guess. He has bilateral calf discomfort after walking 100 meters. However, well, these symptoms do improve if he leans forward. He can tolerate cycling. Pedal pulses are normal. ABPIs are normal at rest and post-exercise. So, any opinions? Dr. Ayman pointed out to that. Yes, that is correct. But any comments on this particular? I don't know. I'm not sure.
Post-exercise does mean he has a very thick or atherosclerotic vessel, so it's not reliable.
I'm glad Dr. Nasser pointed that out because this is our upcoming case, I guess. Or maybe...
What did you do for the second case?
As Dr. Ayman al-Samadoni pointed out, this is a wrong referral. It is neurogenic claudication because it does improve. First of all, he has palpable pedal pulses. It does improve on leaning forwards. There are a few other things that I think may be interesting to differentiate. That the claudication distance is variable. It's not fixed, as in the arterial cases. So he may sometimes walk 100 meters, sometimes 50, sometimes 200. So yeah, it's a wrong referral. As Dr. Nasser Said pointed out, which was going to be the fourth case, but I think it's appropriate to put it here, a dialysis-dependent diabetic, presents with atypical exertional leg fatigue. ABIs is 1.28 bilaterally. Toe pressure is 38 millimeters mercury. So anyone would like to comment on that? I mean, Dr. Nasser did point to that, but anyone else would like to?
This is end artery disease. This is effect هنا بعد الميجور فيسلز في الليفل بتاع الكابيلاريز اللي هو اند ارترايتس. يعني ده اند ارترايتس بلاترانس اللي بيظهر في الكيدني كيسز، وفي الديابيتس برضه ممكن يظهر. يبقى الانكل بريكال اندكس كويس والبيدال بالس محسوس، لكن الافكت على البريفري هو الموجود. يبقى ده على مستوى الديجيتال، وده بيحتاج ديجيتال بلاتيزموجرافي عشان يتأسس.
Yeah, that's an interesting take on the case, but yes, I think it is a calcium issue in the wall of the vessel, and calcium, too much calcium, I think, will make this artery non-collapsible, and it would give us a high, a falsely high pressure reading. So, what about a 59-year-old smoker who's presenting with a bilateral buttock and thigh claudication, has erectile dysfunction, and he has fatigue on climbing the stairs on examination. He has bilaterally weak femoral pulses, ABPI of 0.52 bilaterally. He has a CT angiogram that demonstrates distal aortic occlusion extending into the common iliac arteries. Now, this is a more, I guess, advanced case than the previous ones. So, any comments from the floor? Yes, someone mentioned the diagnosis as Leriche syndrome. What about the management? Yes, sir.
Still, I would manage him conservative management. He's young. I don't want to do intervention at this stage. I don't want to put synthetic on this stage. And one of two scenarios, either he will improve after 3 months with double antiplatelet therapy with the best medical treatment with risk factor modification, or he doesn't. If he does improve, end of the story. Then if he doesn't, then I will put into vascular management.
Okay, I appreciate Dr. Amar's opinion. Anyone else?
Yes, I think the best medical treatment here يعني البروجنوز بتاعه it is not good لأن احنا aorto iliac occlusive disease plus definitely internal iliac artery occlusion.
Yes.
So the best medical treatment here is not the first option. I think revascularization, whatever, endo or open. I prefer in that case open if you can clear the internal iliac bilaterally will improve the benign dysfunction. And I think the patient may care much with benign dysfunction rather than claudication.
So I guess, yes. So this is the key word. I guess what just Dr. Nasser said is actually the key word to choose between a trial of a conservative treatment versus a revascularization procedure is how much this erectile dysfunction is bothering him, I guess. Dr. Tariq.
بص يعني it's an interesting case طبعا interesting discussion بس هو generally ال threshold for intervention for proximal disease أقل قوي من الديستال disease.
Yes.
يعني لو عندي واحد زي ده aorto iliac occlusive disease وclaudication distance هبقى يعني leaning أكتر ناحية الانترفنشن عن اللي عنده infrapopliteal disease مثلا.
Especially with the 0.52 ABPI.
بالظبط.
Yeah.
فيعني هنا ممكن نديله trial of conservative زي ما الدكتور عمر قال if he's not very bothered by the claudication. حتة الإريكتايل dysfunction دي يعني we can make no promises. ما يعني الريفاسكولاريزيشن مش بالضرورة قوي إنه هيصلحها.
That's important to mention to the patient, I guess.
You have to make sure. يعني مش في كل الحالات برضو يا ناصر يعني لأن في حالات هي بص بتعتمد طبعا على الاناتومي والانترنال الياكس افكتد ازاي. لو عندك مثلا توتال ممكن انت الريفاسكولاريزيشن هيحسن لك الفيمورال فلو وممكن قوي الباك فلو ده ما يكونش كافي انه ريفاسكولارايز ذا بلفس. فما نقدرش نبروميس ذا بيشنت ان نقدر نبروميس ان الكلوديكيشن يتحسن طبعا، لكن حته الريكتايل ديسفانكشن دي we have to be careful.
Yes, obviously, yes, we have to mention that there are no guarantees.
أنا my comment according to the CTA
Yes.
that he has only distal aortic occlusion extending to the common iliac arteries, and CTA is very conclusive if we see all the cuts and all the angio. You didn't mention that he has internal iliac artery disease. So the percentage of improvement of erectile function, I think it is high in this patient. Because
Okay.
he will perfuse a normal internal iliac artery.
So we've talked about deciding between revascularization versus conservative. Dr. Mustafa, I think you wanted to say something.
Yes, لان احنا دايما يعني في كذا حاله اللي حضرتك ناقشتهم والناس اتكلمت فيها، احنا بنغفل البيشنت بريفرنس.
Yes,
يعني لو مريض عنده 500 مترز كلوديكيشن واحنا هنمشيه كونزرفاتيف ومتفقين على كده، بس المريض مش ساتسفايد بكده، عايز يحل مشكلته. نفس الحكايه المريض الاخير ده لو هو مش مقتنع بال يعني محتاج تو بي انترفيند وذ، هل هتوافق المريض على رايه ان هو تعمل له انترفنشن؟
Sure.
ولا هتتمسك ان انت تمشي كونزرفاتيف؟
Now, this may be a good opportunity to talk about what the term patient preference in the literature means. The patient preference does not mean what the patient wants. The patient preference means that if there are two different treatment modalities that could be applied for the same patient with equally acceptable results, then at this point the patient preference may have a bearing, as Dr. Mustafa pointed out. But this will come later in the guideline when we talk about informed shared decision making. Dr. Omar.
انا عايز اخد من وقت حضرتك دقيقتين بس. ليا تو كومنتس. الاولاني وات از كونزرفاتيف تريتمنت في الحاله الاولانيه. كونزرفاتيف تريتمنت احنا لازم نبقى واضحين قوي. هو حاجتين مكتوبين في الكتب. كنترول ريسك فاكتورز يعني سموكينج، دايابيتس اتسترا. ثانيا ميديكال تريتمنت اللي هي انتي بليتريت، انتي كواجلانت اللي اضيفت اخيرا اتسترا. لكن في حاجه مهمه احنا قد نغفل عنها، والواي فاي كلاسيفيكيشن بينت اهميتها اللي هي الفود كير. لان عيان الانترميتنت كوميونيكيشن او فانكشنال اسكيميا ده بيبقى متلصم بكميه الدم. ايه اللي بيحول عيان فانكشنال اسكيميا الى عيان ثريتند اسكيميا؟ لازم في انسيدنت تحصل. الانسيدنتس دي ممكن تكون كراكس في الدراي سكين بتاع الهيل تعمل انفكشن، ممكن تكون انتر ديجيتال انفكشن تعمل انفكشن، ممكن تبقى تحت نيل انفكشن. لازم تحصل انسيدنت. فلازم في الكونزرفاتيف تريتمنت يبقوا 3 حاجات مش حاجتين: كنترول ريسك فاكتور، ميديكال تريتمنت بكل حاجته، انتي بليتريت اتسترا، باكسلان، انتي كواجلانت. لكن الثالث واللي اكدت عليه الواي فاي كلاسيفيكيشن الفود كير. الحاجه الثانيه وانا عجبني كلام الدكتور سعيد جدا، ان يا جماعه الاوتو ايلاك والكومن فيمر اصبحوا في الجلاس كلاسيفيكيشن دول انفلو، والتعامل مع الانفلو مختلف تماما عن الاوت فلو. في الجلاس كلاسيفيكيشن الاوت فلو بيبدا من السوبرفيشال فيمر ارتر الى الفوت ارترز، لكن الانفلو هو الاوتو ايلاك والكومن فيمر. والكونزرفاتيف تريتمنت في الانفلو الحقيقه لازم يتاخد يعني بعمق اكتر من كده. انت صعب تكونزيرف قوي في انفلو ديزيز عن اوت فلو ديزيز. شكرا.
Okay, thank you, Dr. Omar. We will talk in another case about the transition from claudication to CLTI. But regarding this particular case, when deciding between the therapeutic revascularization options, and I may use it as just a vote here, who would favor open bypass surgery, aorta byfam? How many? Please raise your hands, please. لا ما خلاص احنا the previous discussion was open versus previous discussion was conservative.
Now
versus revascularization. طيب, let's say we're going to go ahead with revascularization. So who would favor aorto-bifem versus endovascular options? The CT was there. Where's the slide? معلش بس هي جت في آخر السلايد معلش. Okay. يعني let's say what is written there is the image.
It's better to see the images of the CT angio to decide which open or endo.
The images only are the deciding factor, or is there another factor? بس
الريسك فاكتورز الكاردياك كونديشن بتاعك
دكتور طارق. yes
يعني مش بس الايمج، فكل الحاجات دي بتدخل في البتاع. انما لو if he's healthy cardiac wise 59 aortoiliac occlusion I would prefer open surgery طبعا.
Yes.
If the iliac bifurcation is patent.
So I guess this sentence here needs clarification. So if he has fatigue from climbing the stairs, it should be further investigated to decide on his cardiological and pulmonary functions, and this may affect the decision as well. Thank you.
What about adding aorto-penile bypass? If his problem is the type, there is doing something for the penile arteries.
I wouldn't do any direct revascularization for the penile arteries. بس زي ما الدكتور عمرو بيه قال if the internal iliacs are healthy and you bypass the occlusion ده
في حالة لو هم مش healthy عشان كده من prefer الاوبن في حالة زي كده عشان you can add aortopenile bypass if there is this is his major problem.
ما عنديش داتا عن الحتة دي.
تاخد لم من
على الانترنال إلياك اقصد؟
لا مش الانترنال، البنايل ارتري، البنايل ارتري على طول. لا مش قوي كده يعني. ماشي مايكروسكوبيك اي حاجه المهم يبقى في حاجه.
So I guess we're kind of drifting away from the claudication, but
Fuad, I would like to ask. I mean, if the CT image shows that the internal iliac is coming from a patent iliac bifurcation, endovascular solution would be very easy.
Yes.
While if it's not, open surgery would solve the problem.
So I guess easy versus durable, and I think it is durable as well, but not as surgery. This case is about a 64-year-old man who smokes, had insulin-dependent diabetes, chronic kidney disease, and high blood pressure. He has progressively disabling right calf claudication. At 75 to 100 meters, symptoms have become occupation limiting, despite 6 months of best medical therapy and supervised exercise. On examination, he had a palpable right femoral pulse with nothing below. There is no tissue loss. ABPI is 0.58. He has a duplex scan that shows a long segment SFA occlusion with popliteal reconstitution. What is the treatment? Does anyone want to tell us? Dr. Omar Basha?
I will definitely treat it endovascular. Number one, if conservative does not work, then you go for intervention. The aortoiliac segment, there is a lecture in EuroPCR last week mentioned that aortopelvic disease is not a vascular disease anymore, because the incidence of doing intervention just for aortoiliac occlusive disease is nearly gone. Because now the statistics that treatment of recanalization aortoiliac disease with the new device is reaching 100%. The problem with the old aortoiliac disease is the recurrence due to myointimal hyperplasia. Now we have modality with the drug-eluting, especially with the second generation, that you can deal with any aortic occlusion. So for this patient, I will try to use atherectomy devices and then try to use drug-eluting technology. Hopefully for his age, try to leave nothing behind. But if this doesn't work, then I will rely on drug-eluting technology, which now have FDA approval to be done because of the longer-term patency and because he's also insulin-dependent diabetic. So this is straightforward, is being booked for SFA angioplasty plus atherectomy, vessel preparation, and drug-eluting technology.
Thank you, Dr. Amar. I think, Dr. Amar, if you were talking about aortoiliac occlusive disease, that is why there is no update for aortoiliac occlusive disease in the 2025 guideline. But the question now is for infrainguinal, namely, in this case, femoral-popliteal occlusive disease. And you clearly pointed out, if we're going to go with the endovascular option, what should we do? Any other opinions? Conservative. He's tried that. He had 6 months of best medical therapy and supervised exercise. Yep. Excellent. So what does SET mean? Supervised exercise. Well, I guess it's that's we're gonna mention this. Yes. Yes, that's not supervised, right? Yes. Yeah. Very good. So this is a man who has tried supervised exercise therapy, and he has tried 6 months of best medical therapy, and he still has an occupation limiting. And I do like the term occupation limiting as opposed to lifestyle limiting. So lifestyle limiting could be a man who doesn't really work very much, but he maybe likes to have long walks anyways. But anyways, it's different than when you can't do your job. So I guess it's not a question of if we're going to do conservative treatment or not. I think we will need to do revascularization. But the question is endovascular revascularization the only option for this patient, or is there another option?
Let me tell you.
Yes, Dr. Amr,
Dr. Omar Al-Farouk said that the first option for this management of this case is endovascular revascularization.
Yes.
And I agree with that. But I see that the use of atherectomy, vessel preparation, and drug-eluting balloon is to some extent a big cost for the patients, especially in Egypt, if he will pay in his own or even is insured by any insurance company. I do for these cases usually a subintimal angioplasty, SFA subintimal angioplasty, and the results are very good. I have good series, and I think I don't speak at myself, like in the literature, subintimal angioplasty is very successful in these cases if we have very good popliteal artery reconstruction. And by the way, I don't use stents, never use stents in subintimal angioplasty. Subangioplasty alone is enough. Sometimes you find some irregularities, mild vessel intimal flapsole dissections. Leave it like that. If you do angiography after 2 weeks, remodeling will occur, as long as there is no flow limiting dissection. You will see that, and also Amanbolia does the same policy, and he doesn't put stents except very rarely. This is my policy in these patients to lower the cost in our country.
We will talk about there is a specific part of the updated guideline in favor of what Dr. Omar actually said, because in claudication, maybe in CLTI it's different, as Dr. Omar pointed out. Okay. By the way, yes, bypass surgery is still an option if the patient has a single segment great saphenous vein, but that's globally. Okay. Yes. What about a patient who was previously managed conservatively for claudication and now presenting with nocturnal foot pain relieved by dependency? He has a toe ulcer and an ABPI of 0.32. His angiogram reveals a multi-level disease, femoral, popliteal, and tibial. I think this case is more suited for what Dr. Amr Kashif was talking about a couple of minutes ago regarding the Wi-Fi and the glass classifications. But would anyone like to comment on this case quickly, because we have to shift to the guidelines? Dr. Nasser, yes?
Critical limb ischemia according to API figure.
And the symptoms?
And currently still endo is the first in such critical cases. So still have option for endo, whatever in it, the type of endo. And the last option for me is will be open.
Yes.
According to.
Okay, so there is a conceptual difference in the treatment of claudication versus CLTI. And in claudication, we are aiming to improve the quality of life. In CLTI, we're trying to save the limb from being lost. And that would translate into a difference in treatment. So in claudication, if we have a multi-level disease such as this one, femoropopliteal and infrapopliteal, if it was claudication, we would only treat the femoropopliteal segment if we're going to treat it. But in a CLTI patient, it is preferred to have an inline pulsatile blood flow going to the foot. So we have to do correction of both levels in this case, probably either by totally endovascular, or maybe a hybrid procedure.
You didn't mention what type of TUS. So
yes.
TUS 2 now is not.
Yes.
Is not leading.
Yes, and that is why we don't know exactly what we're going to do, but we do know the principle of the intervention. Thank you. But it's for intervention, obviously. So yes, now to the guidelines. So yes, we all know that it's the most common symptom of peripheral artery disease, intermittent claudication. Usually present with a host of risk factors, comorbid conditions, a wide range of disability, and different treatment goals for different patients. Again, what we were talking about a couple of minutes ago, that informed shared decision-making hinges on comprehensive evaluation of the previously mentioned factors. Patient education is very important because definitely most patients do not know the nature of their disease, so we have to explain it to them. And for the physician, he has to know what is the latest available evidence. Now, in 2015, the Society for Vascular Surgery published a clinical practice guideline on the management of asymptomatic peripheral artery disease and intermittent claudication. Now, then, 10 years down the line, an expert writing group was commissioned to provide a focused update to this guideline on the management of intermittent claudication, and they chose certain parts of it. That's the document, if anyone would like to refer to later. Now, in this focused update, the questions were formulated spanning the areas of first antithrombotic management, and I do like the term antithrombotic because it does encompass both antiplatelets and anticoagulants. They talked about exercise. They talked about revascularization for intermittent claudication, specifically for the infrainguinal disease. Now, other sections in the previous guideline were not selected for this update because they were felt to remain relevant, so there is no need to change them. And these segments were about the epidemiology, the diagnosis, other forms of medical therapies, such as the drug we are all here for today, venetidrofuranil or silostazole, and post-procedural surveillance. They remain the same. Now, the majority of new data on peripheral vascular intervention considered here focuses on the femoropopliteal segment, with relatively little new level 1 evidence on aortoiliac disease, as Dr. Omar Al-Farouk pointed out. Came up with 12 recommendations, including 2 best practice statements. Again, they're talking about the dual pathway of antithrombotic strategies, antiplatelet plus anticoagulant, the role and type of exercise therapy, as Dr. Nasser pointed out, endovascular interventions for femoropopliteal and infrapopliteal disease, what to do or not to do, identification of specific risk factors that should be incorporated into shared decision-making around revascularization. Now, number 1, first recommendation, patients with peripheral artery disease and claudication who have 1 or more high-risk comorbidities, such as those, and who are not at high risk for bleeding, we suggest the use of rivaroxaban 2.5 milligrams twice daily in addition to aspirin, low-dose aspirin, rather than aspirin alone, to reduce the risk of cardiovascular mortality from strokes and MIs. The second recommendation is the same as the first one, but they're talking about people who have undergone surgical or endovascular intervention for symptomatic peripheral artery disease, including claudication, and who are not at high risk for bleeding. It's the same recommendation, again, rivaroxaban and aspirin, again to reduce the cardiovascular mortality, but also to reduce limb-related complications such as acute limb ischemia or major amputation. Third recommendation is patients with claudication who do not have high-risk comorbidities and at the same time have an increased risk of bleeding, or they did not tolerate the dual pathway. Then we recommend the use of single antiplatelet therapy, whether aspirin, Plavix, or clopidogrel, obviously, or ticagrelor. Again, patients who have undergone endovascular intervention in particular, we suggest the use of dual antiplatelet therapy for at least a month rather than single antiplatelet therapy. Fifth recommendation, patients who have completed a supervised exercise program and or refuse or cannot participate in a supervised exercise program, we recommend a home-based walking program. اللي هو احنا في مصر بنسميه 100% of cases. In patients with claudication, we recommend the supervised exercise program consisting of walking a minimum of 3 times a week, half an hour to an hour per session, for at least 12 weeks as a first-line therapy. First line. Even before cessation of smoking, that was new to me. In seventh recommendation is patients who have undergone revascularization for claudication, we suggest the continued use of exercise therapy post-intervention, سواء supervised or home-based. دي برضو كانت جديدة بالنسبة لي شوية، لأن عادة احنا بنقول بنسترس قوي على موضوع الاكسرسايز لو هنمشي في الكونزرفاتيف تريتمنت، انما لا هنا حتى even after intervention كمل برضو على الاكسرسايز. Yes sir. Yes, sir. And the quality of life. And the cardiovascular mortality. So the 8th recommendation is in patients who are being considered for revascularization. Being considered, the decision is not taken yet. We recommend that shared decision-making conversations, Dr. Omar Al-Kashif كان بيتكلم عن النقطة دي, should include each of the following risks and benefits that are anticipated after revascularization, such as mortality, major adverse cardiac events, major adverse limb events. What is the functional gain? What is the health-related quality of life? And this is a best practice statement. كل ده بنناقشه. والninth recommendation هي again برضو لنفس هؤلاء المرضى اللي هم are being considered إنه هذه shared decision making conversation مش بس كلام، لا that you have to do an assessment of individual risk factors known to influence the risks and benefits. يعني الهيستوري والexamination لوحدهم مش كفاية، يعني ممكن أحتاج أعمل further investigation for key comorbidities، بس لازم أتشيك الهيستوري of prior limb revascularization، أشوف الanatomic complexity of the disease، هل هو multi level, long segment, chronic total occlusions. من ضمن الحاجات اللي هنتكلم عليها برضو في shared decision making procedural strategy, open surgery versus endo. Again, this is a best practice statement. 10th recommendation. We recommend against performing revascularization in patients with claudication based solely on hemodynamic measurements or imaging findings. Treating patients, not lesions, I guess. No evidence to support the use of revascularization for modifying disease progression. يعني مش هقول أنا هعمل intervention عشان ما يدخلش في CLTI، مفيش حاجة اسمها كده. Actually, it could be the other way around. 11th recommendation. Patients with claudication, no signs of CLTI, we suggest against the use of infrapopliteal revascularization, either alone or in combination with a more proximal intervention. There is no evidence for that, and it could actually be harmful. In patients with claudication who are selected for, this is the last recommendation, who are being selected for an endovascular intervention to treat femoral popliteal disease and have lesions exceeding 5 centimeters in length. هنا الكلام اللي الدكتور عمر فاروق كان بيقوله من شوية هي دي 12th recommendation. Recommend the use of either a bare metal stent or a drug-eluting device, سواء balloon or stent, over plain balloon angioplasty. بس الايه في claudication يا دكتور عمرو مش في CLTI. To reduce the risk of restenosis and need for reintervention. ده it's a strong recommendation. Level of evidence برضو كويسة مش وحشة level B. عشان هو مش عايزين multiple low yield procedures في عيان claudicant وكل مرة النتائج تبقى أوحش من اللي قبلها. Now these guidelines reflect the available body of evidence. الكلام ده على فكرة مش كلامي بقى اللي بعد recommendations هو كلامهم برضو. Reflect the available body of evidence and are subject to reassessment and revision as new knowledge emerges. They do not represent a statement of the standard of care, nor do they substitute for clinician judgment or supplant the patient preference or shared decision making. And the reader must rely only on their own judgment to determine which practices and procedures, whether included in this guideline or not, are appropriate for them, their patient, their institution, or their practice. Well, kind of دي حاجة قانونية شكلها كده أكتر منها أي حاجة بس I think it's absolutely correct يعني. And this is just one guideline. The reader should also refer to other relevant multi-specialty guidelines. I think they're talking about in America, for example, the ACC, the American College of Cardiology, the American Heart Association, and the anesthesiologists' societies on general cardiovascular risk management and pre-op evaluation for patients with peripheral artery disease and claudication to supplement this update. Thank you. أنا مبسوط إني سمعت صوتك الأول.
Thank you. It's also the dilemma in my mind that always guidelines still consider what we all subconsciously believe, that amputation is a failure.
Yep.
No one is discussing when to do an amputation clearly.
Yes.
We have clear things. When you have a non-salvageable limb, there is no doubt about it that the foot is or unreconstructible disease with desert foot, despite that actually there are advances with deep venous revascularization now. But from history, I mean, when we didn't have the advanced endovascular treatment, we used to do amputation primarily if the patient is very frail, very fragile, very old. The functional capacity of the patient is not that good, and he needs an extensive bypass or a long bypass, especially if he doesn't have a vein. When the endovascular emerged, there was a paradigm shift about how to manage these patients, and we believed that actually if you can do some sort of revascularization endovascularly, this will be better than doing an amputation. But there is a gray area that actually I started to face these patients more frequently now. There are patients who were recently in the ICU, frail patients. I'm not talking about age as a number, because there are patients who are 80 plus and they're very well.
You know what they say, age is just a number.
Yeah, but I'm talking about patients who are unfit generally, or they were in the ICU recently, or generally very not functioning. I think we have to do some research about this category of patients. If this patient needs a straightforward endovascular treatment that can go in and out very quickly and do something, fix it, and that's it, that's well and good. Redo surgeries in these patients carries a very high risk of mortality and amputation. So I think this actually something that we need to look forward, but I think that no one would like to do this because all of us subconsciously consider amputation as a primary, or after a primary endovascular intervention is a failure. So I think the guidelines don't spot any light on this category of patients as well.
Because it does not generate enough revenue, I guess. But Dr. Ayman Al-Samadoni wants to hear something about
just a couple of days ago in our MD exam, I put the question in the patient with, I think this that you said was, like I said, an end-stage arterial disease, if you can mention it like this, whether to do, what's your decision-making regarding primary amputation versus attempting at something, and what are the factors that governs this decision? Okay, so still it is, yes, I'm agreeing with you, there is no clear guidelines or clear cutoff when and when, okay? It's still a judgment of a senior vascular surgeon who decide, yes, it has a hope, we can do something to this patient, no, we cannot, let us go for amputation, and amputation is a way of treatment, not a failure of treatment. And that's all we should keep to. But just a comment on the recommendation number 11 that you mentioned.
Can't remember what that is, but okay, go ahead.
If the patient has a multi-segment disease and it's coming with intermittent claudication, and so you should tackle the femoral popliteal rather than the inferior popliteal region. Okay. The problem is that is a minute that you have to resist your own ego. I mean, you are there, the wire is there, the balloon is there, and the patient is on table, and I have the angiogram.
So I guess what Dr. Ayman Samadoni is talking about, do not be trigger happy.
The problem is what seems to be an innocent lesion on the angiogram, because it's only a 2D, sometimes it causes you a nightmare. I mean, okay, that's something in TBT, let us do it first and then go for our initial target, which is a femoral popliteal disease, and you do it, and dissection, and then the acute thrombosis of the inferior popliteal, and you turn your life and the patient lives into hell in a second.
Wisdom.
Okay,
Dr. Omar Al-Farouk.
Yeah, thank you very much. It was fantastic lecture, and I can see a rising star in vascular surgery. Best of luck.
Maybe a fading one, but thank you.
I will just add two things. Number one, last week in Boston, United States, it was done first in human robotic femdistal bypass. This is done by Da Vinci 5.0. And just to let you know that Elon Musk said in 3 years' time, no one should go to medical school.
Interesting.
Because, and this is one of the reasons why Elon Musk is in China, because he wants to grab the robotic technology. So we might be in our profession regarding young generation, rising star, I would ask them to get robotic experience as soon as possible. And this is the attitude we follow in the Royal College.
Thank you, Dr. Omar. I did want to go to China, but now I have a reason.
Yeah. The second thing is, it's always was difficult to me to know what is the best guideline for this patient. You need to read the European, the American, the AHA, and the ACA as well. So I have created a program by artificial intelligence because I am also a Google developer. And this program, you just make an input, what are the patient criteria and presentation. And the program asking you for missing point, like CT angiogram, like duplex scan, and he will go and search all available guidelines, and he will get you the best applicable guideline to this patient with the reference. I think there is a company in States that want to do a program like this, and I hopefully will put it to all my dear friends to use it as well. At the moment, it's only by Google Cloud, so I have limited amount of token to use it, but hopefully I will get you this soon. And you can, while you are in the clinic, put the patient data, get the reply, and I was astonished that he got a lot of Duxiam and Praxillan as recommended, because it will write your prescription, give you the cost of the prescription, and give you the patient advice at the end of the clinic, and they tell you where is the nearest pharmacy to get these drugs.
Dr. Omar,
thank you.
Dr. Omar, I would like to say something. I think what Dr. Omar is referring to is the Nokia moment in vascular surgery, or the Kodak moment. If we do not embrace future technologies and think that they are of no value at the moment, we may be actually left behind. And it is important to not miss out on such a very rapidly evolving and developing field, and don't be so judgmental. Thank you, sir, for doing this. Dr. Amr Gad.
Thank you, Dr. Fuad, for this very nice, comprehensive illustration. I would like to add 1 second that when Dr. Nader mentioned about primary amputation, yes. I would find excuse for Dr. Fuad because his talk is about sure. Asymptomatic and intermittent claudication.
Sure.
Thank you, Dr.
But
Fuad.
It's of educational value. Thank you.
We are short of time.
Thank you.
By 15 minutes.
Appreciate it. Now I hand the microphone to my dear friend, Dr. Krolos.
طبعا فرصة ان انا قاعد في وسط علماء اجلاء، والدكتور فؤاد الحقيقة اتكلم اكتر حاجة على الجايد لاينز. انا بس بذكر العلماء الاجلاء دول كل واحد منكم في مكان مسؤول عن دكاترة اصغر منه، فرسالة بقول لكم عليها تبلغوها كل واحد في اسم او في مستشفى للدكاترة اللي تحت ايده. انا من ضمن الناس اللي في قانون المساءلة الطبية. الجايد لاينز هي اللي بنستند عليها في التحقيقات. احنا بيجي لنا العيان الشاكي الدكتور والدكتور وبنكتب الدكتور ده ليه مدان او مش مدان حسب الجايد لاينز. فرساله ببلغها للعلماء الاجلاء لكل واحد في مكان يبلغ الاطباء اللي عنده اللي شغالين تحت ايده لما تاخد قرار في عيان. العيان احنا في برانش الفاسكولار بتاعنا الكومبليكيشن اكتر حاجه، يعني الاوت كام بتاعنا عشان نكون صراحه مع بعض. نعم.
طب كفايه كده بقى.
لا
لو سمحت في ميعاد صلاه ولسه فاضل 3
بس ببلغكم بس الحاجه دي ان الحساب اي مريض بيشتكي دكتور الحساب انت اتبعت الجايد لاينز ولا لا. شكرا.
زي حضراتكم مش هنطول ان شاء الله عشان الصلاه برضو. اتس بليجر ان ابقى وسط حضراتكم وسط اساتذتي جميعا يعني. Optimizing outcomes in pelvic venous disease with dubocilate. Pelvic venous disease could affect women and men. Why we talk it in women؟ بسبب ان الفينس سيستم في الفيميلز مختلف تماما عن الميلز، بسبب انه all are connected through اول الرينال فين connected للبرفوريتورز بتاعت الليج through hypogastric and pelvic leak and lower limb veins. A difference between pelvic congestion syndrome and pelvic venous disease. اي فيميل عندها pain pelvic pain هي بتتسمى pelvic congestion syndrome without any investigation. بسبب وده بسبب ان ميلكا جرينر classifies this patient into 3 categories. Type 1 هو simple venous reflux. Type 2 هو reflux due to obstruction شبه الميترن او نوت كراكر. Type 3 هو local gynecological cause. فكل دول اسمهم pelvic congestion syndrome if these patients have a venous disease excluded by gynecological causes, so this is called pelvic venous disorder. So pelvic venous disorder have a specific definition and a specific line of management written clearly in guidelines, and have a tool specific written by Mark Meisner called the SVP tool. I will go quickly just to rule out how why some venous pathology causes different symptoms in cohort patient, why some symptoms in cohort group of different venous pathology, because there are 4 venous system, 3 reservoir and pelvic leak points, and specific tool, SVP tool classification. For example, we have 4 zones. First one is the abdominal, the left renal vein is the incriminated vein. Zone 2, the hypogastric and gonadal veins. Zone 3 is the extrapelvic, driven by pelvic sources, and zone 4 is the lower limb. For example, I would like to point out just one. If this patient have left gonadal vein reflux, the main reservoir should be the pelvic reservoir. So with the help of pelvic floor muscles and normal venous system, all the pressure here transmitted directly for the pelvic reservoir. If this patient, which is called the uncompensated pelvic state, transmitted directly to the lower limb, it's called decompressed or compensated pelvic state. So why some patients have a pelvic pain and other have a lower limb pain, in spite that both patients have a gonadal vein reflux, it's all about the pelvic floor muscles and the level of decompensation and pelvic leak points. For example, another example, patients who have non-thrombotic renal vein occlusion, pressure could be transmitted directly for the renal vein, so causes hilar varicosities, or could be transmitted through gonadal vein to the pelvis, even to lower limbs. So we might have two patients of symptomatic nutcracker syndrome. One have loin pain and the other have pelvic or extra pelvic varicosities. Gluteal obturator and guinal obturator veins and pudendal veins are interconnecting, and in the real pelvic escape points, these pelvic escape points are normally closed and it open when the big. And this pelvic leak opens when patient have pathology. Mark Meisner developed a tool which is the symptoms various pathophysiology. Symptoms start from patient being asymptomatic or renal, pelvic, extra pelvic. Varices could be renal or pelvic or extra pelvic, and the pathophysiology, it's with the anatomical hemodynamics and the etiology. Most of these patients, if she have a lower limb varicosities and symptoms, should be accompanied by SEEP classification. Gluteal obturator, perineal, inguinal, and point are the points seen. Perineal is the most common, followed by inguinal. Inguinal and obturator points are seen in the anterior pelvis, while perineal and gluteal seen from posterior pelvis. Gluteal and obturator seen inside true pelvis, while perineal and inguinal outside true pelvis. Inguinal is incriminated in recurrent anterior accessory veins. Obturator is incriminated in medial thigh recurrent varicosities, and gluteal veins incriminated mainly for gluteal or sciatic varicosities. This is a recommendation in guidelines for patients with varicose veins of pelvic origin without pelvic symptoms. Pelvic venous embolization as an initial treatment should not be performed. For patients with varicose veins of pelvic origin with pelvic symptoms requiring treatment, pelvic venous embolization should be considered to reduce symptoms. For patients with suspected suprainguinal venous obstruction, in addition to full leg duplex assessment, ultrasound of abdominal and pelvic veins should be considered as part of initial assessment. For female patients with pelvic pain and clinical suspicions of pelvic venous, exclusion of other causes of pain is recommended, so to exclude Grainer type 3. For patients presenting with symptomatic varicose veins where there may be pelvic origin, specific duplex ultrasound assessment of pelvic escape points is recommended. For female patients with suspected pelvic venous disorder, abdominal and transvaginal ultrasound should be considered to confirm presence of venous pathology, and this is the primary screening tool. For patients with varicose veins of pelvic origin without pelvic symptoms requiring treatment, local procedure like varicose veins and related pelvic escape point should be considered as initial therapeutic approach. Pelvic vein reflux has been identified both in women and men, as we said, but really it's seen more in women due to the interconnecting venous channels. Why calcium diboxylate? As we all know, it works on mainly capillary permeability and vascular endothelial growth factors, and in mTOR pathway, fibroblast growth factors, nitric oxide, and autophagy. So it have an anti-inflammatory and antioxidant property. Why we use calcium diboxylate specifically in pelvic congestion syndrome or in pelvic venous disease? Because it reduces vascular permeability and improve venous tone, reduce congestion, and help in venous return of these reservoir and zones that we have said, and management of underlying venous insufficiency. So when we see patients who have pelvic-derived lower limb varicosities and who have pelvic and lower limb, especially who have recurrent, when we examine this patient, we might think of who have sciatic varicosities, so we should screen for gluteal and sciatic veins. Anterior accessory, we mainly incriminated in inguinal veins. Here are some cases where patients who have pelvic congestion syndrome underwent left gonadal vein embolization, whether by glue or by coil or foam sclerotherapy. It might be isolated left gonadal or right gonadal vein prior and post embolization. Calcium doboxylate not only help in this medical treatment before embolization, it's after embolization, because it have a rule in post embolization syndrome. I just want to point out some really important uses of calcium doboxylate in malformation. Here's a case of Merit, 39-year-old patient who have chronic pelvic pain and excluded all gynecological cause. Greener 1, she have pelvic and extra pelvic. She have varices in pelvic and extra pelvic, and she have isolated left gonadal vein reflux of non-thrombotic origin. We started calcium doboxylate prior embolization from 3 to 6 months, then followed by left gonadal vein embolization and coiling, then continue medical treatment. Here is the duplex examination. Here is the arcuating and stasis in the pelvis, and here is post embolization. I would like to emphasize in one important use of calcium doboxylate. I really use it a lot in pediatric population. As we all know, calcium doboxylate, we can't use it systemic for pediatric, but we can use it topical. How? Because we use it, yes, doxyproct, yes, because it works on mTOR pathway. mTOR pathway is incriminated in capillary and lymphatic malformation with venous, especially children who have cloves, who have Klebel Trenaunay syndrome. So, because it works on vascular endothelial growth factors and vascular stabilization. So we have two pathways mainly in venous malformation. It's called rhasopathies or bicopathies. Bicopathies is BIK3. We might the main genetic factors in this is gain of function of the gene incriminated in venous malformation. So, for example, if a patient have Klebel Trenaunay syndrome, it's incriminated due to BIK3 overactivity, which is the main enzymatic of mTOR pathway. So these children, we give them orally sirolimus or rabamycin for controlling the bleeding and venous pain. Whether we will undergo this patient for laser ablation or for venous intervention. Here we don't have any mTOR topical directly as sirolimus, but we can use calcium doboxylate because it inhibits mTOR, which will inhibit BIK3. So we can use calcium doboxylate as a topical in children who have venous malformation, cloves, or Klebel, but we can't use it for children who have Barker-Weber or RAS pathway because it's another genetic basis. I will show two cases. So calcium doboxylate is not target treatment in AVM, but in venous low flow, and especially in post-embolization syndrome. It's a relation between calcium doboxylate and sirolimus. Sirolimus work directly on mTOR pathway, but calcium doboxylate through enzymatic activity that lead to mTOR pathway inhibition. In children, we give sirolimus systemically, while we can use calcium doboxylate topically in children. This first case, a Ratib, 18 years old child who have Klebel Trenaunay syndrome. Patient was on medical treatment in form of systemic sirolimus and topical calcium doboxylate. Then we excluded deep venous insufficiency or deep venous obstruction. Patient underwent a high frequency laser 1940 laser ablation of the cervical vein, which was draining in profunda partially and partially through iliac vein. Then underwent sclerotherapy and exolaser. Here is prior. And here is after 3 sessions of medical treatment, endovenous laser ablation, then 2 sessions of pulsed dye laser and long pulse NDAG and injection sclerotherapy. The last case is Nermeen. She have the same Bross syndrome, who have lateral marginal vein of cervical, Weber type 2. She have a huge cervical vein draining into profunda femoris and iliac. She have a port wine stain. Calcium doboxylate can reduce pain if this is an adult who take it systemically or a child who use it topically. And here is post intervention after endovenous laser ablation and foam sclerotherapy. Thank you. دوكسبروكت حتى بنعرف الام يعني بنقول لها وهي بتشتري من الصيدليه ما تستغربيش الصيدلي قال لك ده بتاع بواسير او حاجه عشان ما تتخضش. هو عيبه في الاسم فعلا في اليوز لما بنيجي نكتبه للامهات يعني اي بي.
Mohammed, thank you very much for trying to wrap up the venous. I mean, pelvic venous order is a wide thing. To wrap it up in 30 minutes or so, that's really great. The thing that, what's your opinion when I should suspect there is a pelvic pathology in compensated cases of pelvic vein disorders, where the patient is presenting with a lower limb rather than with the pelvic symptoms, when I should suspect there is a pelvic something? I mean, the testing, the transvaginal, transabdominal, I mean, that needs a very dedicated dietitian to perform the test. And where he see areas of uncommon reflux, so he would follow it up to find a leaking point and so on, so on, so. I am the one who transfer the patient, so I need to guide him where to go. So some patients, I will go to any dietitian, but you go to a specific dietitian. What are the criteria clinically?
Yes.
I should raise alarm, raise a flag. Yes, we need a pelvic study.
Yes. شكرا دكتور ايمن يعني حضرتك استاذي ودايما حضرتك تقول لنا هاو تو سيلكت ذيس بيشنت. طبعا اول حاجه الهيستوري تيكينج في كل الطب عامه مهم بس في ذيس بيشنتس مهم جدا الهيستوري تيكينج والجنرال اكزامينيشن واللوكال اكزامينيشن للفاريكوستس. مثال دايما حضرتك عارف ان الاكزيال فاريكوز فينز غير الاكسترا اكزيال في منظرها فلما بيشنت بتيجي عندها اكسترا اكزيال فاريكوز فينز وما بتشتكيش من pelvic symptoms and I probe and I ask her of pelvic symptoms وبتبدا تريز لان في المعظم البيشنت بتبقى جايه لدكتور الاوعيه شاي وجايه كونسيرن بتاعها رجليها لان هي ما تعرفش ان المشكله اللي عندها في البلفس ليها علاقه بالدكتور الفاسكولار سيرجري. عشان كده we have to probe this question ان لما بنلاقي extra varicose veins لازم قبل ما اقول هعالج فينز ولا لا لازم رقم واحد يكون عندها symptoms. So I have to ask وبالترتيب اكتر اسئله بتبقى مهمه جدا هي الديسمينوريا والديسبارونيا اكتر من الطبيعي. فلما دايما عشان كده اول ما بيبقى فيه سيمتومز على طول رقم واحد ترانسفاجينال دوبلكس. الترانسفاجينال دوبلكس مع دكتوره ديديكيتد هي اللي بتقول كذا حاجه. اولا السايز 5 مللي والاركويتنج ونقطه مهمه قوي قوي ان الترانسفاجينال هو السكريننج تول لان هو اللي بيشوف الانترنال الياك فين ريفلكس لان زي ما حضرتك قلت ممكن تبقى كومبنسيتد وفي الجونادال فين نورمال وهي مشكلتها ملي في الهايبوجاستريك فين. فعشان كده دايما البيشنت دول التريتمنت بتاعهم بيبدا من اول الميديكال تريتمنت لان هو بيدي كومبنسيت البلفس وبيحسن السيمتومز شويه بعد كده بنديها ميديكال تريتمنت وبنخلي دايما لو العيانه جايه لي برايمري ما عدتش على دكتور نسا بخليها ترجع لدكتور نسا لان العيانه لو اتعالجت على اساس ان هي بلفيك فينس ديزيز وهي عندها لوكال جينيكولوجيكال كوز عمرها ما تتحسن. بس تمام يا بيه. اي اسئله؟ اتفضل يا بيه اتفضل اسئله. اتفضل دكتور نصر.
Use high dose for short time or small dose for lifelong.
في البلفيك يا بيه ولا في
whatever في الفينس insufficiency.
في الفينس insufficiency
بالنسبه للكالسيوم دوبسيليت.
I usually write for pelvic veins من 3 ل 6 months وبنتابع symptoms in form of SVB tool اللي it's dynamic and visual analog.
بعد 6 شهور لقيت السيمتوم رجعت يبقى تستمر.
هستمر.
مش كده؟ يبقى هي لايف لونج برضه.
حتى يعني بوست امبلايزيشن كمان حتى لو دخلت انت يعني بوست امبلايزيشن بنكتبها من 3 ل 6 months.
طيب هي الريكومندد دوز بقى اللي هي ال 1000 توايس ولا 500 3 تايمز which is the best؟ لان احنا يوزد كنا بنستخدمهم 500 توايس زودناهم بقى 3 مرات لكن دلوقتي في 1000.
مظبوط. I usually write 500 توايس لان I think بيبقى اذا حضرتك ال 1000 برضه ممكن يكون فلافينويدز. هو الكالسيوم دوبسيليت ال 500 بكتبه مرتين.
بس في ريكومنديشن ممكن تستخدم ال 1000. وريلايبل يعني.
يعني ما عنديش كلير داتا في ان ممكن we can use 1000 بس I think we can use 1000 فلافينويد. انا خلاص
احنا عشان الوقت طبعا انا بشكر الدكتور محمد حجاج، والحقيقه بس انا احب اقول دكتور محمد من الناس اللي عندنا في القسم اللي ديديكيتد فعلا لموضوع البلفيك كونجستشن والارتيريو فينس مالفورميشن. يعني هو معظمنا يعني بالحالات الاي في مالفورميشنز دي ما بنحبهاش يعني وبنحاول نهرب منها شويه وبتاع، انما هو الحقيقه واخد الموضوع ده اتس فيري ديديكيتد ليه ومشترك عندنا في الدمرداش بولي كلينيك مالتي ديسيبلينري كلينيك للاي في مالفورميشن بيدخل فيها البيدياتريشنز والبيدياتريك سيرجنز، وهو بيمثلنا كفاسكولار سيرجري وجماعه بتوع الانترفنشن ايديولوجي والبلاستيك سيرجري. يعني في كذا حد الحقيقه داخل في هذه الكلينيك وهو فيري انترستد في الموضوع ده، وبنشكره على كده وبنشكره على البرزنتيشن.
شكرا لشركه مينا فارم على هذا التجمع العظيم وسيمبوزيوم الحقيقه رائع ساينتفيكالي، والدسكشنز كانت فيه مفيده جدا. واي ثينك ان مينا فارم عايزين ياخدوا جروب فوتو، فاتفضلوا. كل